That means that we're going to have a recorded lecture that you guys need to watch on your own. And then I'll have everything that you need to have done by Sunday of that week. And then I'll also include a PowerPoint that you guys should have for class. Were all of you guys able to download and have that PowerPoint? Awesome. So we're going to be going through that today. That's going to take up a lot of our class time. At the end of the PowerPoint, I included a lot of practice problems and also a Kahoot game. If we don't get to all the way to the end of that, I'll make sure to post that for you guys in the course cafe. I'm planning, if you guys want, we can try and skip break and just get out like 10 minutes ish early, like end at like 7:55, 8, or we can take our normal break and go to 8:11. What would you guys prefer? Raise your hand if you want to get out early. Okay. All right, I think we got a majority. So we're going to skip the break. I'm pregnant, so if I got to get up and pee, you guys are just going to have to bear with me here. So that might happen. But we'll try and get out here then by like 8 o'clock. Okay. So let's go ahead. If you guys will pull up that PowerPoint that I had sent in for class, we're going to start going over that. Okay, okay, let me share my screen here and we'll get rolling. All right, is everybody able to see this? Awesome. So my PowerPoint that I have for class is a little bit different than the one that I sent you guys. The one that you guys have goes into a little bit more detail on specific things. And then mine has an extra slide regarding RH incompatibilities. So when we get to that slide, if you need a screenshot or whatever, please feel free to do that. I'm also going to be posting this recording like we did last week to our shell, so you guys will have it to reference, okay? A lot of this will require you guys to like kind of answer and like tell me what you guys are thinking too, because we're gonna work through some questions together, okay? Alrighty, so kind of reviewing from week one, a nurse is providing teaching to a woman about the fallopian tubes and fertilization. The nurse knows the teaching was effective if the client states what? What do we want to know about the fallopian tubes?
Isn't that where fertilization goes to?
Yeah, fertilization occurs in the fallopian tubes. Yep. From an anatomy standpoint, what 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 does the where do the where are they?
They connect the ovaries to the uterus.
Yep. The fallopian tubes are passages between the ovaries and the uterus, and that is what the egg travels through. And it's also where fertilization takes place. So you guys are definitely going to want to know that. Fertilization takes place in the fallopian tubes. What happens if a zygote implants in the fallopian tube? What would that be called?
Ectopic pregnancy?
Yep, that would be an ectopic pregnancy. Where should it implant?
In the uterus.
Yep. Specifically, what layer? What is the layer of the uterine lining?
Uterine wall, I think.
It would be your endometrium.
Oh.
No worries. So, ectopic pregnancies. This is really important for us to know, specifically where we have implantation. Because if an implantation occurs in the fallopian tube and we have an ectopic pregnancy, that would be considered an OB emergency. This is because if a pregnancy that is forming in the fallopian tube becomes too progressed and gets to a certain size, we run the risk of having the fallopian tubes rupture, right? So if a fallopian tube ruptures, we're worried about hemorrhages, we're worried about maternal death, a whole lot of things. The mom will lose a fallopian tube, which most OBGYNs say that that does not actually limit or decrease your fertility because you would still produce around the same amount of eggs. However, for some women, like say they only have one fallopian tube, you know what I mean? Like there's different cases where this may not be true. So we're worried about ectopic pregnancies. We also want this pregnancy to implant specifically in the endometrium because if it implants further into the uterine lining past the endometrium, we're getting down towards like muscular cells, muscle and everything like that. That would be called an accreta, which we'll learn that more about that when we're talking about OB emergencies later whenever it comes to labor and delivery. But we really want to make sure that it's implanting in the endometrium. Okay. What are three comorbidities that can contribute to a high risk pregnancy?
Diabetes.
Diabetes, yep.
Hypertension.
Yep.
Obesity.
Yeah. Yeah, you guys got them. Hypertension, diabetes, and obesity. Those are the three big ones. Okay. Hypertension, I would say, is probably one of the more serious ones that we're talking about because, like I said, or talked about in our lecture, um, hypertension, if you have high blood pressure, that's going to be constricting those vessels, which is going to impede blood flow to the placenta. And blood flow to the placenta is overall means oxygen to baby, right? So if we don't have good blood flow to our placenta, we're not going to have a well oxygenated baby, and that can pose a lot of risks to the baby. For diabetes, what we're worried about with that is diabetic moms are predisposed to a lot of different unfavorable outcomes. One of the biggest ones would be having a really, really large baby at birth, which we would call that a macrosomic infant. Big babies also can lead to another OB emergency, which we call a shoulder dystocia. Shoulder dystocias occur when the baby's shoulder gets stuck under the mom's pelvic bone whenever the baby's crowning and about to be delivered. And that can lead to the baby having a clavicle fracture, a brachial plexus injury. It can cause moms to hemorrhage. So, this is kind of why we want to keep, why diabetes is a big one that we're worried about for sure. All right. What populations have a higher overall rate of maternal morbidity and mortality? Your book talks about this a little bit more than I did in our slide from the first week.
I believe is Black women and Native Americans.
Yep, African Americans, American Indians, and Alaskan Natives are the biggest patient population that we see that have a higher increased risk of maternal morbidity. Okay. What are the three phases in the cycle of violence?
Is that the acute or abuse, the honeymoon, and the tension building?
So it would be honeymoon, the tension building, and then abuse incident. So you have like the honeymoon phase where everything is all like good and dandy, everybody's happy, lovey-dovey, very affectionate. Tension building when there's like little fights happening, bigger fights happening, it builds and builds and builds and builds, and then the abuse incidents occurs. So last week we talked a lot about human trafficking and then abuse. So um, as a nurse, what are some things that you could assess your patient? What are some symptoms that a woman who is currently being abused or is in human trafficking would show? Like how would she act? Or what are some things you could see?
She may not speak for herself. If maybe her trafficker's with her, they'll try to overtalk her and answer for all of her statements.
Yep, definitely. What else?
She may not know answers to questions like what's your address, where do you live, basic things. She may have to think about or look to her abuser to see what to say.
Yes, definitely. Those are all really good ones. Some other things that we would may notice is bruising or old wounds or different or wounds in different stages of healing that don't line up to whatever the reasoning is behind them that the woman or the partner says. A partner that is not willing to leave her alone in the room with healthcare professionals. If she's not making eye contact, if she's very hesitant to speak, those are really big ones. So as a nurse, like we need to be pretty mindful with how we care for this patient. We're not going to just like burst in her room and demand that the person that's with her leave because that is going to cause both the patient and the partner that or the other person that's present with her to be a little skeptical and not trust the nurse, right? So biggest thing is we want to build trust with these patients. If we get the opportunity to talk to them alone, we need to use that opportunity to talk to them and ask them and interview them about the abuse they're facing and help them formulate a plan. Okay. So, this is definitely some things that we see a little bit more of when we're talking about maternal and newborn medicine because we're talking about that patient population that is at a high risk of abuse. What are two screening tools for women's health the nurse can educate a woman about?
Mammograms.
Mammograms, yep. What's another big one?
Pap
smear.
smears.
Yeah, pap smears. So a pap test and a breast exam. So we can educate our patients about that. And then how can a nurse ensure that she's meeting the standard of care? So when we're talking about standard of care, what are some things that nurses need to do or keep up on that help prevent errors or whatever? Like what are some things that is our responsibility in the healthcare field to do?
Continuing education.
Yeah, continuing ed. Big one is evidence-based practice, right? And then following your hospital policy. So utilizing policies and procedures from the facility. Um, so those are really important. But when I'm talking about standard of care, we also need to talk about like neglect. So whenever we were going over week one content, we talked a lot about what is neglect, which is basically anything that falls underneath the standard of care. Any action or inaction done by a nurse that falls underneath that standard of care would be considered neglectful. So I want you guys to know that for your quiz and for your exam. So, and with evidence-based practice, it's our role as nurses to make sure that we're completing and doing um, bedside procedures correctly per evidence-based practice and per hospital policy. Okay, so like if we need to change the way that we're practicing because there's new evidence-based practice that comes out with something that's better, then we need to do that. Okay, it's our job and our role to keep up with it. All right, so as you guys were listening to lecture, as you guys were kind of looking through your content for this week, who was super confused by the GTPAL? We're going to go over this pretty extensively because you will 100% see a question about this on your exam and most likely on your HESI. Okay, so let's kind of break it down. Let's go over this really quick. So when we're talking about GTPAL, we're talking about gravidity and parity. Okay, so gravidity is the number of pregnancies that a woman has had. And that is regardless of the outcome, okay? Whether it was a full term baby, preterm baby, spontaneous abortion, miscarriage, elective abortion, ectopic pregnancy, whatever it may be. If it's a pregnancy, it's a G. If it's the pregnancy, it counts towards your G's. Parity is the number of deliveries after 20 weeks. Okay? So this is a little bit different whenever we're just doing G's and P's because so to kind of give you guys some context. If I'm going on to the floor and I'm going to get a report from a nurse, I'm not going to get the full GTPAL breakdown. Okay? In the nursing units, we just talk gravity, parity. We talk about how many times the lady has been pregnant and how many children she's delivered after 20 weeks of gestation. Okay? The OB offices use GTPAL more for them, for their reference, so they know the woman's full obstetric history. Okay? So in that full mnemonic, G still stands for gravida, which is the amount of time somebody has been pregnant. T is your term delivery, which is a delivery that's over 37 weeks. Preterm is your P, which is a delivery of an infant between 20 weeks and 36 weeks and 6 days of gestation. A would be your abortion, and that is a delivery less than 20 weeks. So, like I said, ectopic pregnancy, spontaneous abortion, elective abortion. And then your L is your living. Okay? So when we're going through these problems, it's really important to know what each one of these stands for because that's going to help us whenever we're practicing. So let's go ahead and practice some. A client on postpartum just delivered a son at 37 weeks. She has a daughter at home that was born at 28 weeks and a son that was born at 38 weeks. What is her GTPAL? So let's go through it one at a time. How many times has this patient been pregnant? What is her G?
Got a better chance.
Three.
3. How many term deliveries has she had?
Two.
2. How many preterm deliveries has she had?
One.
1. How many abortions?
Zero.
0. And then how many living children does she now have?
Three.
3. Correct. Because this patient just delivered. So that does count as a living child. Does that make sense to everybody? Okay. A pregnant multipara has a son who was born at 35 weeks, a set of identical daughters who were born at 36 weeks, so those are twins. The client also delivered a stillborn 2 years ago at 38 weeks and had a spontaneous abortion 7 months ago. What is her GTPAL? What is her G? How many times has this patient been pregnant?
Four.
So this is where twins get a little confusing. She's been pregnant here 5 times. So so she's currently pregnant, so that counts as 1. She had a son who was born at 35 weeks. That's her second pregnancy. A set of identical daughters who were born at 36 weeks. So with a twin pregnancy, you still only count that as 1 pregnancy. Okay. She had a stillborn 2 years ago at 38 weeks. That's her 4th pregnancy. And then she had an abortion at 7 months ago. So that's her 5th pregnancy. Okay. So don't let the twins thing confuse you because twins are still only considered 1 pregnancy. Okay. How many term deliveries has this patient had?
One.
Correct. 1. How many preterm deliveries has this patient had?
2.
Correct. 2. Because we have that 35-week boy who was born, and then the twin delivery still only counts as 1 delivery. So in this mnemonic, your G's and your P's for twins is just going to be one pregnancy and one preterm delivery. How many abortions has she had?
One.
Correct, one. And then how many living children does she have?
3.
Three. Yep. So your L in this mnemonic is the only time where the twins are going to be considered separate. Everything else is going to be just considered with one. Okay. Any questions on that? Awesome. A multigravida delivered a daughter at 28 weeks and had 2 spontaneous abortions at 12 and 14 weeks. Is this client a primipara? And what is her GTPAL? So what does primipara mean?
Your first pregnancy? Your first delivery?
Delivery. Yeah. So think about it in this way. Your G means gravida. So if you see multigravida, your G here, gravida means total number of pregnant. So if you see multigravida, that means she's been pregnant multiple times. Para would align with your parity. And so then you have to think first time. Oh no, not first time living children. So P and just the G and P would be living children. So your parita would be living children or child born after 20 weeks. So when you're looking at it this way, it's asking, is this the first time that she's delivered a baby after 20 weeks?
Yes, it is.
So she had, what would her GTPALs be? Let's go through that. So how, you had any term delivery?
No, she has 0.
Zero. For preterm delivery, though, she had that daughter that was 28 weeks. So that would be a preterm delivery. How many abortions has she had? She's had 2, correct. So then how many living children does she currently have? Awesome. So I think this is the only other practice one. So do you guys have any questions so far about this? Okay. Awesome. So we're going to go through kind of a little bit of a case study here. Abby is 17 years old and she comes to the prenatal clinic. What symptoms could Abby be experiencing that would cause her to think that she is pregnant?
Cramping,
Cramping.
spotting,
Yep.
A missed period.
Mm-hmm.
Nausea.
Yes, definitely. Yeah, you guys got them. So amenorrhea, she misses her period. She's having some breast changes and tenderness. She's having nausea and vomiting, urinary frequency and fatigue. All of these things a patient can experience that may lead her to think that she's pregnant that don't necessarily mean that she is. What would we call these signs?
Presumptuous.
Presumptive. Yep, presumptive signs of pregnancy. You got it. So in class, we talked about presumptive, probable, and positive signs of pregnancy. So that's kind of where we're moving now. So it's important. We're going to go through that and like kind of match up presumptive or probable pregnancy signs. So Abby states that she's never been pregnant before. If Abby is pregnant, would she be considered a nulla gravida, a primigravida, or a multigravida?
Primigravida?
She would be a primigravida because this would be her first time being pregnant. Okay. If she came to the clinic and she was like, I think I'm pregnant, I didn't have my period, I didn't, and they did an ultrasound and they did not see a fetus, or anything like that, then she'd be considered a nulla gravida because she's never been pregnant. But since she is pregnant, we're calling her prima gravida because she's been pregnant once now. Would she be considered a nullipara, a primipara, or a multipara?
Nullipara.
Nulipara.
Yep, because she has never delivered or given birth to a baby that's over 20 weeks of gestation. And what would her GTPAL be?
One zero 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 zero.
Yep, she is a G1P0 is the shortened version. But yep, that is correct. G1T0P0A0L0. Awesome. All right, so here we're going to be moving on to probable and positive signs of pregnancy. So we're going to go through each one of these. I just want you guys to tell me if you think it's a probable or a positive sign. So a positive pregnancy test, what would that be?
Positive.
Positive.
So this one would be probable. So just because somebody has a positive pregnancy test does not necessarily mean that they are pregnant because HCG can be elevated due to a bunch of different things. Um, Probably one of the biggest ones is an ovarian tumor can cause HCG levels to go up. This you guys don't need to know for like your exam or anything, but I found it super interesting and kind of creepy. But like if you accidentally ingest like a bunch of mouse droppings, it can cause your HCG to go up. Because I had a physician who was doing a like tubal on a 75-year-old and she had a positive pregnancy test and it turns out she lived on a farm and like had an old farmhouse that she had to like mice sometimes come in. So that creeped me out really to hear that. So just a fun fact for you. But no, HCG testing is not a positive sign because other things can cause it. What about if we hear fetal heart tones via a Doppler?
Positive.
That would be positive. Yep, because we are auscultating the baby. You hear that baby. What about our Chadwick sign?
Probable.
Probable. Who can tell me what the Chadwick sign is?
Discoloration like of the vaginal entrance and cervix.
Yep. So it's like whenever it's like a bluish tint, bluish hue to the vagina and cervix. Yep, you got it. Ballotment. Would that be probable or positive?
Probably.
So this one would be probable. So what is ballotment? Do you guys know?
Is it when you can like feel the fetus like with your hand?
Yep. So it would be an examination done by a physician where they're like tapping on like the uterine wall or outside, to feel for fetal movement or to feel like a presence of a fetus. Yep. So that would be probable because so with positive signs of pregnancy, which I want you guys to really know this, is anytime you visualize the fetus in the uterine sac, gestational sac, or you hear the fetal heart rate. Anything else would be considered probable. Okay. So that being said, what about our ultrasound?
Positive.
Positive, yep. Hagar's sign.
Probable.
Yes. And what is it?
It's like a physical.
Of the cervix.
Mm-hmm. Yep. Softening. Yep. You guys got it. Um, and that's usually done by like when physician will examine a patient. they will be able to feel that change. But that would be only a probable sign. What about Braxton Hicks contractions?
Probable.
Probable, yeah. So if a patient comes into the office and is like, I'm having this cramping, I think I'm having Braxton Hicks contractions, I'm definitely pregnant. Like Braxton Hicks contractions are things that we usually only like assign to patients whenever they're like a little bit further along in their pregnancy. That can be a normal thing that happens in pregnancy. Braxton Hicks contractions in the sense of diagnosing a pregnancy, I think would refer more towards just like general cramping. So if a patient is coming in saying they're having cramping and that they suspect they may be pregnant, that would be a probable sign, but we can't definitively say yes or no that you are or not. What about x-ray?
Positive.
Positive, yep, because we're going to be able to visualize that baby. How about uterine enlargement?
Probable.
Yep, probable. Good old sign.
Probable.
Yep, exactly. So you guys got this. Going to be this is going to be like you can't see or hear the babies. That's going to be probable. So then what is our good old sign?
Softening of the cervix.
Yes. What about fetal movement assessed by an examiner?
Positive.
Positive. Because that is actively, we are feeling, we are seeing the baby move. Okay, great job. All right, let's go over Nagel's rule. So, who can tell me how to calculate this? How do we calculate Nagel's rule?
I think
So
it's like
you,
you.
sorry, you subtract 3 months and then add 7 days.
And then you also add a year. Yep. So let's do this practice one. So she tells us that her LMP was July 2nd of 2023. Using this rule, what would be her due date? Someone like walk us through how we get it.
So backwards 3 months, right? So that'd be
April.
June 2nd, May 2nd, April 2nd,
April 2nd. Yep.
then forward a year.
Mm-hmm.
So April 2nd, 2024, and then add a week. So April 9th,
April 9th,
2024.
2024. You got it. Ooh, awesome. So this is one way that we get a patient's estimated date of delivery. That's what EDD means, if you guys were not sure. So, yeah, we would add that year, subtract 3 months, add 7 days. That's going to give us a due date. That being said, though, what's the most reliable way to determine gestational age and due date? Can we go based off of this rule
An
100%?
ultrasound.
Right, we need an ultrasound. Exactly. So what happens is a woman will call into the office, the OB office, and say, I have a positive pregnancy test. My last menstrual period was July 2nd, 2023. They're going to use their little wheel to do or calculate the Nagel's rule, and they're going to put that due date in her chart. Okay. Typically, women will know or find out they're pregnant around 4, 5, 6-ish weeks. Typically, your first OB appointment is scheduled for 8 weeks. So then they go in and they do a transvaginal ultrasound at their first visit. In that ultrasound, they're going to measure the fetus from crown to rump, is what they call it, because we don't at that stage really have definitive, arms, legs development. The baby is still too early. So, crown to rump measurement. And then on that ultrasound, it's going to give them, okay, here's the due date. So say Abby comes in with her due date of July 2nd. They measure that baby and she gets a due date of July 1st. They will not change her due date because it's so close to what the ultrasound is showing. Typically, an OB won't change the due date if it's within give or take 6 days. If it's anything more than that, then they're going to go by the ultrasound. Okay. So, but yes, the ultrasound is our most definitive and reliable way to determine our gestational age and the due date of our baby. All right, so Abby's pregnancy test is positive, and her ultrasound shows an intrauterine pregnancy, which is normal, with a due date consistent of her LMP. What information are we going to want to get from Abby? This is her initial intake, her first time to the office. What do we want to ask her?
How does she feel about finding out she's pregnant?
Yeah, definitely.
Any past medical history?
Past medical history, definitely.
What medications she's taking?
Yes. What else?
Nutrition and exercise.
Nutrition, definitely.
Drug and alcohol use.
Yes. Great. Yep, that's all great. Seeing that she's what we would consider an adolescent pregnancy, what other things would we want to screen? I mean, one you guys said nutrition, which is already a big part of an adolescent pregnancy, but what else?
If she plays any school sports, like contact sports.
Yeah, definitely. We also want to talk to her too about like support system, what her plan is like for her and the baby when they're discharged from the hospital, who will be helping her with childcare, who's going to be helping her with the baby, is she planning to continue in school, what is her kind of long-term plan. We also kind of want to get an idea of her socioeconomic status, right? Just like we do with any patient. We want to know, like, what is their work schedule? What are the requirements that they face at work? What is their income status? You know, are they having concerns about finances during this pregnancy? Okay. So, all of those things. So, we want to get all of this stuff. So, a health history, allergies, we want to know her last menstrual period, any chronic illnesses that she may have, any family history or family health of chronic illnesses. What is her environment like at the house? Where does she live? Who does she live with? Who pays the bills? Like her socioeconomic status, all that stuff. What medications is she taking? Because, like we kind of talked about, some medications are going to be a category C class drug and aren't going to be safe in pregnancy. If she is using um, or goes to the dermatologist or something and she uses retinoids, she's not going to be able to use those in pregnancy. So, educating this patient on all of those things. Herbs, any type of herbal supplements that may be unsafe in pregnancy. So, like with working with the Amish patients, we talked about that a lot because they use only herbs and herbal supplements for medication. So, like staying away from red raspberry leaf tea until you're over 36 weeks of gestation, staying away from other herbs that can be harmful to fetal development. Supplements. So, what is something with, like, what are two big things that we're worried about with adolescent pregnancies? This is kind of working ahead.
Oh, birth weight.
Low birth weight, definitely. What else? What's the other one? With adolescent pregnancies, we're worried about iron deficiency anemia. We see that a lot in this patient population. So we need to talk to her about supplementation, right? Iron supplements. Um, and the importance of doing that and getting her labs drawn routinely to screen her. Mental health screening, that's always important with any pregnancy, definitely with a pregnancy that may or may not have been intended. We want to see how her mental health is doing, if she currently is taking any medications for anything like schizophrenia or bipolar disorder. A lot of those meds are harmful in pregnancy, and we may need to change them or lower or change her dose. Education, like I said, is she planning to go continue in school? What is her education level? What are her plans for that? If she's planning on traveling, where is she going to go? Because if she's going somewhere that requires specific immunizations, she may or may not be able to get them while she's traveling because of the pregnancy. Okay. Immigration status is on here mainly because if she is from a country that has a prevalence of a disease that's not as big in the United States, we need to know about that to be able to screen her for anything abnormal, just to make sure that she and the baby are safe, right? The biggest one that we're talking about with that would be tuberculosis. Tuberculosis can be more prevalent in other parts of the world than in the United States. So if she's been exposed to TB or, has been around or lives with somebody who has been exposed or has tuberculosis, we need to educate her on that. Cultural assessment, we need to know that because we want to be well-rounded nurses that are providing the best care for our patients. So taking into consideration her culture, things that are important to her and things that she wants in this pregnancy versus things she may not. Like we mentioned before, the human trafficking and abuse assessment. Socioeconomic factors we discussed. You guys said substance and alcohol use, which is definitely part of our screening process. This also will include cigarettes and vaping. So I know too for like an adolescent population, vaping has been a really popular thing. So screening her for that and talking to her about potentially quitting or minimizing the amount that she vapes during her pregnancy. BMI is important because, like we talked about at the beginning of this slideshow, obesity can lead to gestational diabetes as well as hypertension. So, obesity and a higher BMI is something that we're going to want to educate the patient on and monitor them a little bit closely for other things. But that also being said, a patient who has a low BMI is also at a high risk. We are more concerned with adolescent pregnancies having a low BMI rather than a higher BMI, right? So these are things that we want to know because like even patients that have a lower BMI who may have like eating disorders or who may just need to increase their daily caloric intake, these patients could potentially delay development of the fetus, could lead to intrauterine growth restriction, low birth weight babies. So um, lots of education as far as nutrition goes. Exercise. So if you have a patient that comes in and she's like, I do CrossFit every single day, twice a day, I'm not planning on stopping, I'm not planning on slowing down. If that's what she's used to doing, technically her OB might tell her, like, hey, that's fine, you might just need to modify some things, right? Um, if you have a patient who comes in and they say that they're a little bit more sedentary, we need to encourage them to try and go on at least an hour walk every day during her pregnancy because maintaining a good exercise regimen is beneficial for fetal development. We're going to go over her nutrition status and her prenatal vitamin intake. Folic acid. What does folic acid help prevent?
It's important for like spinal formation.
Yeah. So what are we worried about with spinal formation? What would that be called?
Neural tube defects.
Yeah, neural tubes. Yep. So an increased amount of folic acid has been shown to decrease the instances of neural tube defects in babies. What are what is the hormone or the other test that we can get from mom that could give us an indication of if the baby's going to have a neural tube defect or not? Do you guys remember?
It's not an anatomy scan, is it?
You would be able to potentially see a neural tube in an anatomy scan, but this is like blood work.
Alpha fetoprotein.
Yes, exactly. Your alpha fetoprotein is something that we're going to collect from mom and it can indicate whether or not the baby is at a high risk for neural tube development. Would it be high or low?
I'm gonna guess high here.
You guessed right. So alpha AFP is going to be elevated in neural tube defects. AFP is going to be low if we have an increased risk for Down syndrome. Okay. And then your family health history. And under your family health history, this would include like any history or instances of any birth defects in the immediate family or any known chromosomal abnormalities, like does a relative have Down syndrome? Were there other babies born with Down syndrome in that same family? That kind of stuff. Okay. So considering risk factors, what assessment and testing would we anticipate for Abby in the first trimester?
Get like a baseline of where her iron levels are.
Yep, so we're going to get labs, definitely. What other assessment things are we going to do at this initial?
STD testing.
Yeah, STD testing, definitely.
Pelvic exam.
Yep, we could do a pelvic exam for sure.
Her vitals, of course.
Yep, vitals for sure, definitely. And vital signs are something she's going to be getting routinely at every appointment because we're going to want to know her blood pressure every time. So we need an accurate weight, an accurate height and weight. We're going to get vitals. We're going to get a urine sample. What are we testing for in her urine?
Protein.
Protein. What else?
Infections.
Glucose.
And glucose. Yep, those are the three things that we're really looking for. So in your urine, we're testing for protein. Because elevated protein in the urine can indicate that a mom is developing preeclampsia, which we'll talk a lot more about in the next couple of weeks. We're going to check for any bacteria in the urine because with moms with pregnancy, you have an increased risk for urinary tract infections. So every prenatal visit, they're going to test the urine for any bacteria that's developing. And then glucose. And the glucose in the urine can be indicative of gestational diabetes. It can also sometimes glucose can start leaking into the urine with hypertension or other things that can happen during pregnancy. Our blood work, we're going to get a routine CBC. We're also going to check a mom's rubella status. And then we're also testing for like HIV and other STDs. Okay. We're going to also want to know this mom's blood type and what is her RH, because we'll talk a little bit more in this slideshow about RH incompatibility and ABO incompatibility. So if a mom has an O blood type or is RH negative, she's going to need RhoGAM. Okay, so we'll talk more about that here in a couple slides. We also want to see if this mom is willing to get a carrier screening to see if she's a carrier for anything like muscular dystrophy, Duchenne syndrome, anything like PKU, and stuff like that. Okay. The alpha fetoprotein, low versus high, which we talked about that. And then our adolescents, they have an increased risk of anemia and low birth weight babies, which we talked about. Okay. So here we are at RH and ABO incompatibility. So there's three main big ones that I want you guys to talk about. And like I said, if you want to take pictures of the screen, you're more than welcome to. All of this information is in your textbook, but this screen is a little bit easier because it kind of like, it makes it a little bit easier to understand and it focuses on the big points. So we'll talk first about ABO incompatibility. So this always has to do with mom's blood type, okay? So when we're talking about ABO incompatibility, it's just talking about her actual type, A, O, B, AB, okay? So if mom has an O blood type, regardless if she's Rh positive or Rh negative, her blood does not recognize A or B antigens and could detect A, B, or AB blood types in the baby as foreign, okay? So, with this kind of incompatibility, the mom's body may already have antibodies to the other blood types. So they're going to attack the red blood cells of the baby with any blood type other than O for the current pregnancy. RhoGAM, unfortunately, is not going to help with this current pregnancy if that is the case. Okay. So sometimes, like, what happens is you'll have a mom who comes in and she might have a miscarriage. And then they draw her blood and they realize that she is an O, and they'll give her RhoGAM like after that, during the miscarriage. Okay. And that's going to help her in the future with other pregnancies. But for this pregnancy and this ABO incompatibility, it does not help with that current pregnancy. Okay. So that's ABO incompatibility. RH incompatibility, on the other hand, occurs if a mom is RH negative and a baby is RH positive. The mom's immune system could detect the positive RH from the baby's blood as foreign and build antibodies against it. Okay. So the antibodies will then accumulate and they can affect a future pregnancy if the next baby is also RH positive. So giving the mom RhoGAM will stop the production of these antibodies. So the mom can receive RhoGAM, and it's typically around 28 weeks of gestation. They'll give that to her, and that will help with subsequent pregnancies as well. Okay. The last one is probably the hardest one to understand. It is a little bit more complicated, but this is our Coombs test. So there's an indirect Coombs and a direct Coombs. An indirect Coombs test checks to see if their antibodies are circulating in the mom's blood. So like if she's an O mom or she is an RH negative, we're testing her Coombs to see if there are antibodies actively circulating in mom's blood. After mom has delivered and after the baby is born, we do a direct Coombs test that can detect if mom's antibodies are present on the baby's red blood cells. So typically, whenever we're getting a direct Coombs, it's through cord blood. We're getting cord blood at delivery. If the Coombs test is positive, it increases the chances for a baby to develop hyperbilirubinemia, which is a really fancy word for the baby has jaundice and some anemia. Okay. This is because those antibodies are going to destroy baby's red blood cells and it's going to release into the bloodstream bilirubin. So then that bilirubin is going to build up in the baby's bloodstream and it's going to cause the baby to look jaundice, and then we're going to have hyperbilirubinemia. Okay. The Coombs test can be used to detect antibodies for both RH and ABO incompatibility. This can also be referred to as a direct antigen test. So if you see a direct antigen test, that is another term for Coombs, a Coombs test. Those are the three main blood incompatibility things that I want you guys to know for this class and for the purpose of your exams in HESI, for sure. Does anyone have questions on that? I know that's a lot of information. Okay. I think the thing that you guys should focus on too, or really know, is when and when not to give RhoGAM, or when RhoGAM will be helpful versus when it's not going to help in a current pregnancy, right? So, and just knowing that RhoGAM is what we're going to be giving a mom who does have the ABO incompatibility or the RH incompatibility. All right, moving back to Abby here. So, Abby is at a prenatal visit. We get her vital signs. Her blood pressure is 110/70. She has lost 4 pounds. Her urine is normal. We listen to her baby, and her baby's heart rate is 140. Her blood type is B negative. She tested positive for gonorrhea. She has a hemoglobin of 9, which you guys, for your exams, you should know what your normal lab values are, for sure. But 9 is low, so she is considered anemic. Her alpha fetoprotein was elevated, which indicates our risk for neural tube defects, and she comes back as rubella non-immune. How would we address Abby's weight? Are we concerned? What do we think about this?
Isn't some weight loss expected initially if she has a lot of nausea and vomiting?
It can be, yeah. With her being an adolescent pregnancy, I think we are more cautious about it just because we really want her to gain not necessarily like more excessive amounts of weight, but we would usually recommend adolescents increase their calories by I think about like 500 a day. We want them to increase their calorie intake. So weight loss for her, for us, would be a little bit more of a educational point where we need to educate her on increasing her calorie intake. But yeah, a little bit of weight loss in the first trimester can be normal just because some people are pretty sick. So we want to talk to her about what our educate her on expected weight gain, what that looks like. We also want to do a nutrition assessment and ask her about her dietary preferences. So in a patient who's anemic, what do they usually crave that indicates that they're anemic?
Ice.
Yeah, ice chips. So they're going to want to keep eating ice chips. So that would be called pica. So we're going to screen her for that. And then this is also a patient that would be someone we need to recommend for a nutritional consult and with a nutritionist because she's already anemic, so we need to talk to her about eating those big green leafy vegetables, um, and then encouraging her for an iron supplement. What are we going to plan to administer at 28 weeks because of her blood type?
Rogan.
Yep, Rogam. What important follow-up treatment and plan would be implemented because she tested positive for gonorrhea? What would we anticipate?
Antibiotics.
Antibiotics. What else do you think?
Getting her partner tested.
Yeah, definitely. So we're gonna do antibiotics. We also want to educate her a lot about this because so she is younger, so we need to give her some good sexual education and preventative measures. But yes, having her sexual partner tested and treated for it as well will prevent reoccurring infection. Now that is kind of the standard. So this has been a little bit more recent, which it makes sense to me. I don't know why this wasn't implemented a while ago. But even if a woman were to test positive for a yeast infection or bacterial vaginosis, it's encouraged that her sexual partner receives treatment as well for it to prevent reoccurring infection. So that is something that we need to encourage her and educate her on. What education would we provide for her regarding her anemia? Or specifically, like if we're going to give her iron supplements, this is going back to your guys' pharmacology knowledge. What are some things that we're going to tell her to do or not do with not anemia replacement, iron replacement?
Don't take iron with dairy products.
Yeah,
Take it on the
It with vitamin C.
Take it with orange juice. Orange
Yeah.
juice.
yeah, you guys are awesome. Yep. How to take the iron. The treatment is typically for 3 months. And this is where, assuming this is by an oral replacement, sometimes if the anemia is really severe, patients will come into the hospital for IV infusion of Venifer, which is just like the IV form. And then you don't take it with milk, tea, or coffee. Take it with citrus fruits and juices. And then we educate her on the fact that it can potentially cause her to be constipated. So if that's occurring, then we need to give her a regimented dose of Colace in the evening and then in the morning. Okay. Her alpha fetoprotein is elevated, indicating a possibility of neural tube defects. What could have decreased the risk of this defect?
Folic acid.
Folic acid. Exactly. And then what's the next possible step in evaluating the elevated AFP? What else would we want to do, like, to diagnose this potentially?
Is it too early to do the ultrasound?
So you're on the right track. So we're gonna want to do an ultrasound, yeah, or an amniocentesis. For this patient, if we see that she has an elevated AFP, she's in adolescent pregnancy, she has anemia, she's already probably going to be referred to maternal fetal medicine or a higher risk OBGYN. Okay. Because she's going to need to get probably ultrasounds or scans almost every 2 weeks. Whereas typically in your first and your second trimester, they see you every 4. For her, she would need to have more frequent testing. Into her third trimester, she may need to be seen as frequently as every week. So, this patient definitely we're going to refer to her to a higher level of care. Ultrasound is going to be what we want first because with her, we're probably going to get her an earlier anatomy scan. Okay. So your anatomy scan in your pregnancy happens typically around 20 weeks of gestation. For a patient who has a high risk, so like if you have a carrier screen that comes back with and flags something, or you have elevated AFP, or you have decreased AFP, or anything like that, they're going to recommend that this patient get their anatomy scan early to see how baby's developing. Okay. Amniocentesis is another way that we can diagnose a neural tube. What are some things that we need to take into consideration about an amniocentesis? Do you guys remember some stuff? When can we do an amniocentesis?
15 weeks.
Yes, 15 weeks of gestation. Why would we not want to do an amniocentesis sooner than that?
Club foot risk.
Yeah, we're at the risk for a club foot. We're at the risk for causing a miscarriage. For moms, her highest risk for these would be like a hemorrhage, maternal hemorrhage. She's going to start, if she starts having cramping and bleeding, causing miscarriages. For babies, we're worried about clubfoot. We're worried about fetal development issues. We're also worried about fetal death or miscarriage is the biggest. Amniocentesis is very invasive, right? So if you guys listened to the lecture already, I included some video that shows you how they do it. But they basically are puncturing through to retrieve some amniotic fluid. And that poses a high risk for mom and baby, right? So this is something that we do only as a last resort if it's necessary. In Abby's case, if she's farther along, she's like 18 weeks or so, we can probably get an anatomy scan via ultrasound, and that might be just enough that and all she needs. Okay. However, if she's still early and we really need it and she really wants to find out whether or not this baby's gonna have a neural tube, then amniocentesis is what we're gonna do. But like I said, it's high risk and invasive, so we try to avoid doing these. What about her non-immune status to rubella? Are we going to worry about this right now? What is the vaccine that we would give the mom, give Abby?
MMR.
Yeah, her MMR. Can you have that in pregnancy? You cannot have the MMR vaccine in pregnancy. So we would just tell her that if she wants the MMR vaccine, she's going to have to wait until after the baby's born. Okay. What additional testing done routinely throughout the pregnancy will Abby be educated about, and what is the purposes of these tests? What do you guys think? Just like, and this isn't necessarily talking about her risk factors, like your standard tests that a woman goes through during pregnancy.
The glucose test,
Yeah, glucose testing.
just to check for gestational diabetes.
Yep, exactly. What other ones?
Urine tests.
Urine tests.
Monitoring blood.
Stress test,
What was that, Mercy?
a stress test.
Sometimes we'll do stress tests. Yep, and that's to assess for fetal well-being. Let's see if you guys got them all. Ultrasound, that one I feel like is pretty straightforward. That 20-week one is talking about their anatomy scan. First trimester for gestational age and dating. Glucose tolerance test is 24 to 28 weeks of to diagnose gestational diabetes. And then your group B. So group B is something that we didn't really talk about too much in the lecture, but we're going to talk about it here now because it is important. So Group B strep is something that we're going to test for about 35 to 37 weeks. Group B is a bacteria that already exists in the vaginal tract of most women. Okay. It is a normal bacteria flora. During pregnancy, though, sometimes that bacteria will increase to dangerous levels to where it is a risk for the baby. Okay. So we need to test these moms. How we do the testing is we take a swab and we swab in the opening of the vaginal canal, and then we take that swab down to the opening of the anus and swab around that, and then we send it off to be tested. We wait until they're about 35 to 37 weeks because we're allowing for any of that GB bacteria to grow. So it's usually at the highest point of the most bacteria around this stage in pregnancy. So she's going to test positive. It will be at this point in the pregnancy. That's why we wait so long. With moms who test positive for GBS, they just need to get antibiotics in labor. That's really it. If they come in and they deliver too fast, or if they deliver before they're able to get their GBS testing done, we have to treat them as if they're positive, and we have to treat and screen the baby as if they've been exposed. Okay. So what that means is we would get like every 4-hour vitals on baby. They'd probably have to stay in the hospital longer. And we just have to be more cautious. Okay. Do you guys know what the antibiotic is that we use for Group B during labor?
Is it amoxicillin?
It's penicillin.
Penicillin.
Penicillin is what we use. So our loading dose is 500 units, and then subsequently we give them 300 units every 4 hours in labor. What assessments are done at each visit and what is the purpose? So this is just like your vital signs, weight, fundal height, urine, and we have talked about all of those already. All right. Whenever we're educating our patient, let's look at all of the normal discomforts of pregnancy. Oh my goodness, it's basically everything. So I said it sounds like one of those like infomercial ads of like a medication. Like if you are experiencing this and then they list every single thing that you could possibly experience. So this is some normal, these here are listed for you are normal discomforts of pregnancy. You guys can see them here. Breast changes, urinary frequency, fatigue, all of this stuff. These things would be considered normal and they're not things that we're going to be concerned about. Okay. Big ones here like supine hypotension. If a mom says, I keep laying down and I will pass out, or I go to stand up and I get super dizzy, like that does not necessarily mean she has blood pressure issues. That's just because, like, what we talked about or what I was lecturing on about like supine hypotension, that can happen in pregnancy and that's not completely abnormal. Okay. What we want moms educated on are potential problems associated with pregnancy, and these are the things that we are going to be more concerned about from a developmental standpoint and a fetal well-being standpoint. So anytime a mom has bleeding in her pregnancy, whether it's the first trimester or the third trimester, we need her to come in and get evaluated. With bleeding, we're not only worried about miscarriage, but we can also be worried about placenta previa, which is what happens when the placenta develops over the cervical opening. We could also be worried about placental abruption, uterine rupture. There's lots of things that we're worried about whenever moms complain of bleeding. Leaking before 37 weeks. So that could mean like if her water broke early. That would be called premature preterm rupture of membranes. Okay. And that would be an indication of preterm labor. Decreased or absence of fetal movement is 100% always something we want moms to come in for to evaluate the baby and make sure baby's okay. Heartburn with a headache, epigastric pain, and the severe headache unrelieved with Tylenol. These three things here, we are concerned about preeclampsia. So we want to talk to the mom about that. We don't want her to have these things. Flank pain can sometimes indicate preterm labor. Sometimes women will just have flank pain and flank contractions whenever they are going into preterm labor. Persistent severe vomiting would be like hyperemesis gravidarum. That's what we would be concerned with that. And that we're worried about our hydration status. Burning on urination, so UTI. Any visual disturbances could indicate high blood pressure. Contractions or pelvic pressure before 37 weeks. And then unusual cravings. So all of these things here, we really do not want to see in pregnancy. And we're going to talk to our patients about that and warn them about those things. All right. So some additional testing that Abby or any other patient might go through would be a non-stress test, a contraction stress test, a BPP, fetal kick counts, Leopold's maneuver, amniocentesis, and ROGAM. So when do you guys think we would need a non-stress test? Or really, what is a non-stress test, I guess?
Well, it would check with the related to the heart, correct?
Yeah, this is assessing fetal well-being. And it's when you put your patient on the monitor and you're looking at the baby's heart rate. Contraction stress tests we're going to use mostly to see if baby tolerates being under stress. We don't really use these that often. They're expensive and they typically are going to stress out a baby, so we aren't really going to be doing them. This is not very reliable. A BPP is done via ultrasound and it assesses for a couple different things, which we talk about on the next slide here. But this is all going to assess for fetal well-being here. So Abby is now 34 weeks pregnant and she realizes she's not felt her baby move today. She has been monitoring fetal movement at home using what she was taught at her prenatal appointment. How would she be monitoring her baby? So how do we educate our patients on what do we tell them to do as far as fetal kick counts?
She could do her kick counts and try drinking some orange juice.
So whenever we're educating a patient on doing kick counts, how do we tell them to do the kick counts? Like what are we telling them to do?
Is it at least counting 10 kicks or movements within an hour?
Within 1 to 2 hours. Yep. Yep. So we want her to do these daily fetal movement kick counts. So you want to do them at the same time each day. The goal is 10 movements in 1 to 2 hours. She tries to do fetal kick counts and feels one kick in an hour. She lays on her side and assesses a little bit longer but does not feel any further movement. Abby calls her doctor. What do you think her doctor is going to tell her to do?
Come in to be seen.
Yep. We want her to come in so that we can put this baby on the monitor. She arrives at the clinic and is placed on the fetal monitor for a non-stress test. Abby's fetal heart tracing has minimal variability and no accelerations. Is this a reassuring or a non-reassuring stress test?
Non-reassuring.
Correct, non-reassuring. So what assessment findings would be considered reassuring on an NST? Like what would we want to see?
You want
Multiple variabilities.
We want to see moderate variability, yep. So here are your guys' guidelines for an NST, and I would definitely know these. okay? Because you might need to answer whether or not an NST is reassuring or not. So, baby's heart rate or baseline should be between 110 and 160 beats per minute. We should see moderate variability and at least two accelerations that last more than 15 by 15 seconds without any decelerations. That would be a reassuring NST. So, to those of you who have never read a fetal heart rate monitor or fetal heart rate tracing, this verbiage or terminology may be really confusing right now, but we're going to go through fetal heart rate strips and tracings in a couple of weeks, and we go through it really in detail, and this will make a little bit more sense. But for now, I just want you guys to know these findings and what assessment findings indicate a reassuring NST. What test, oh, excuse me, may be performed now based on the fetal heart rate tracing? So you've had a non-reassuring NST. So what test are we going to do further? What else do you guys think we'll get?
Would they then do an ultrasound?
Yes, and in the ultrasound, what are we going to test specifically? It's kind of another exam that's done by ultrasound. We're going to get a BPP. So that's typically the order you see things done. So a mom will call in and say, I haven't felt my baby move in 2 hours. I've laid on my side. I've drank a huge big thing of orange juice. I've drank some water. I'm not feeling anything. We're going to tell her, okay, come in. We'll put her on the monitor. We'll get a non-stress test. A non-stress test is usually 20 minutes. That's how long we're looking at the monitor. You can evaluate whether or not a NST is reactive or not in that 20-minute time frame. If she has a non-reassuring NST, we're going to get her a BPP, this biophysical profile. So to help you remember, it kind of says like, it kind of looks like Batman, just without the A. So it's BATS MN. So a BPP tests for fetal breathing, AFI, which is your amniotic fluid index, which is how much amniotic fluid is present, baby's tone, their movement, and then the NST. So it basically does an NST at the same time as doing the ultrasound. If the fetal score is below 8, then we're going to be doing further testing and potentially this baby might need to be delivered early or we might need to figure out what's going on. A normal BPP would be anything 8 or higher. Okay, so you guys definitely need to know that. Awesome. So let's move on. I think I got some practice questions here. Okay, so we're kind of moving on to some practice things. And this goes a little bit in depth on some other stuff that we want you to know. So it's like a little matching game. So out of this here, what do you guys think? Early fetal movements often noted as a fluttering typically felt at 18 to 20 weeks gestation. What would that be?
Quickening.
Quickening.
Yep. Ooh, I thought it was gonna like do something. Nope. Yeah, that's quickening. Violet bluish coloration of the vaginal mucosa and cervix as early as the 6th week. What would that one be?
Chadwick's sign?
Yep. Your irregular, painless contractions that facilitate uterine blood flow and facilitate oxygen to the uterus, to the fetus.
Braxton Hicks?
Yep, you got it. Then that creamy, whitish yellow to orange pre-milk fluid expressed as early as 16 weeks gestation.
Leukorrhea.
So this one would be
Colostrum.
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 Yeah.
Yep. The way it's like written, it's like, where is that coming from? But yeah, that would be colostrum. So your uterus becomes globular shapes, softens and flexes over the cervix, which can compress the bladder. What would that be?
Urinary frequency?
Yeah. And then your white or slightly gray mucoid discharge with a faint musty odor in response to cervical stimulation by the hormones estrogen and progesterone is your leukorrhea, which is normal in pregnancy. Awesome. All right, moving on to our practice questions here. A pregnant client comes to the maternity clinic for a prenatal visit on June 6th. The LMP was December 10th. At which measurement does the nurse expect to find the fundus? So how many months is she?
6.
Yep. So what do you guys think her fundal height will be for this pregnancy, for this stage?
26 centimeters.
Exactly, 26 centimeters. You got it. A woman's last menstrual period was on April 1st of 2019. She's been keeping her prenatal clinic appointments regularly, but states she needs to alter the dates of a future appointment because she and her husband are going on an ocean cruise vacation for the New Year's celebration from December 30th through January 7th. The best response of the nurse would be,
See?
perhaps you might consider rescheduling your vacation around the Thanksgiving holiday rather than the New Year's dates. Yes. So what would her due date be if we do Nagel's rule?
January 8th.
Let me do this math, but I believe that's correct. Basically, it's when she's going to be on vacation. So, would that be a good time to travel and go on an ocean cruise? No, sorry, ma'am. You can't, you should not be doing that. So, yeah, April minus a month would be March 1st, minus a month would be February, 2 months would be February 1st, minus 3 months would be January 1st. Add that 7 days, that's April 8th. So, yeah, I mean January 8th. So yeah, she's there basically during her due date. So no. We're going to have her move that. The nurse is counseling a client who is at 6 weeks gestation and is experiencing morning sickness, but does not want to take any drugs for this discomfort. What herbal supplement is likely to help this client with the nausea that she's experiencing?
Ginger.
Ginger. Yep, ginger is a big one that can help with nausea and vomiting. The other ones, I don't even know if they're safe in pregnancy. So, we definitely don't want to recommend that. When reading the OB history of a client who is currently at 36 weeks gestation, the nurse notes that she has had one full-term infant, one preterm infant born at 32 weeks gestation that survived, and one miscarriage. What is her gravidity? How many times has she been pregnant?
4.
4.
Yes, because we need to count the pregnancy that she currently has. So yeah, she is a G4. Which topic is most important for the nurse to include in a nutritional teaching program for pregnant teens?
Iron
C.
C.
Yes, iron deficiency anemia. Because we said they're at the highest risk for a low birth weight infant and iron deficiency anemia. During the 32-week antepartum visit, a prima gravida, so what does that mean, prima gravida?
First pregnancy.
First time pregnant.
Yep, she complains of a backache. Which assessment finding indicates that this complaint is related to a common discomfort of pregnancy that occurs during the last trimester?
A.
Yeah, what is lordosis?
Like further curve of the lumbar area.
Yeah, and that can happen in pregnancy. That mom's back can kind of just like start curving just because the baby's developing and everything is kind of shifting around. She's going to be way more uncomfortable. So, yeah, lordosis and back fatigue after standing for most of the day. When we're teaching a gravid client how to perform kick fetal movement counts, what instructions should the nurse include?
A.
A. So, we want her to have those 10, if 10 kicks are not felt within 1 hour, drink orange juice and count for another hour. Counting the movements once daily is correct, not correct, but we tell them to count at the same time every day. We want them to be paying attention to it throughout the entire day. So, like, if it's already like 2 o'clock in the afternoon and they haven't felt the baby move at all, they need to like do some kick counts and figure it out or come in to be seen. Right? So it's not just like oh, you did it once today, you're good. Like it's kind of you're in the back of your mind thinking about it. Avoid caffeinated drinks for 24 hours. That does not matter really. And then exercising for 15 minutes before starting the counting to help increase fetal movement. That's not really going to do that much either. So, like, exercise isn't really going to affect whether or not that baby starts moving. A nurse is teaching a client at 5 weeks gestation about nutrition. Which information is accurate for the nurse to provide this client regarding caloric intake during pregnancy?
D.
D. She should eat a balanced diet and make adjustments as needed to promote proper weight gain. Yep. All the other stuff is not necessarily correct information, so we don't need to be emphasizing anything, but making sure somebody gets a well-balanced diet and making adjustments as they need to is going to be more beneficial. Okay. The nurse is assessing a pregnant client who reports that she smokes 1 pack of cigarettes a day. The client believes she is 6 months pregnant but is unsure of the date of her last menstrual period. Which method of assessment provides the best estimate?
C.
Yep, our ultrasound. Ultrasound is always going to be the answer when it comes to Beth's method of gestational age or dating. The nurse in charge is reviewing a patient's prenatal history, which finding indicates a genetic risk factor.
B.
B. Yep. So when we're talking genetic risk factor, that is including things like cystic fibrosis. Her being 25 years old is not a genetic risk factor. Being exposed to rubella is not a genetic risk factor. It's just something that we're going to need to educate the patient on. And a history of preterm labor does not mean anything genetic wise, but it does mean that she is at an increased risk for instance of preterm labor with this pregnancy, which is something we do want to educate her on, but it's not going to be anything related to her genetic makeup. Which of the following are the functions of amniotic fluid? Select all that apply.
Cushions the fetus from abdominal trauma.
Mm-hmm.
Maintains internal temperature.
Yep.
A, C, and D.
Yeah. A, C, and D. It cushions the fetus from abdominal trauma. It maintains the internal temperature and it facilitates fetal movement. What is is B? What part does that?
The umbilical cord.
Your placenta. The whole placenta will provide oxygen and nutrients to the baby. A nurse has discussed teratogens with a client during preconceptual counseling. The client demonstrates understanding after making what statement?
D, as in dog.
Yeah. Yes. Exposure to teratogens poses the greatest risk during the first 8 weeks. That is correct. So she doesn't necessarily need to stop all of her meds, right? That's a little extreme, especially if the medications that she's taking are safe in pregnancy. We're not going to worry about that too much. The fetus is at greatest risk for developing anomalies during the first 16 weeks is not necessarily true. We're talking mostly in that first trimester, okay? And then after 12 weeks, the placenta protects the fetus from teratogens. That is not right. It doesn't really matter when somebody is exposing a baby to to these things like substances or anything like that. It's still going to affect the fetus regardless of gestational age. We just say that the exposure to these things poses the greatest risk during the first 8 weeks because that's when your risk for miscarriage is the highest, those first 8 weeks of pregnancy. The nurse is assessing the umbilical cord of a newborn. Which finding constitutes a normal finding?
C.
Yep, 3 vessels, 2 arteries, and 1 vein. You guys may see that again. A pregnant client asks about the functions of the placenta. Which items of information should the nurse include in the discussion with the client?
Fetal respiration, nutrition, and excretion. C.
Yep. So fetal respiration, nutrition, and excretion are carried out by the placenta. The placenta will not filter alcohol from mom's blood. Fetal and maternal blood mix within the placenta to exchange oxygen and nutrients. That is not true. And then oxygenated blood from the mother is diffused into the fetal blood as it is channeled through the umbilical cord. That is also not true. So I went through in our recorded lecture that I posted to you guys the full circulation of blood flow from mom to mom, baby, and all of that, and how that works. Definitely have an understanding of that for your exam. Okay. I also talked in a lot of detail about our ductus arteriosus and the foramen ovale. You guys will want to know what those structures are for sure. All right, another GTPAL question. You'll see these a lot, I think. A pregnant client is making her first antepartum visit. She has a 2-year-old son born at 40 weeks, a 5-year-old daughter born at 38 weeks, and 7-year-old twin daughters born at 35 weeks. She had a spontaneous abortion 3 years ago at 10 weeks. Using the GTPAL format, the nurse should identify the client is. So let's work through this one together here. So how many times has she been pregnant?
5.
5.
Yes. How many term deliveries has she had?
2.
2. Yes. How many preterm deliveries?
1.
And then how many living children? I mean, abortions. Sorry, I missed. 1.
1.
1.
And then how many living children?
4.
Yep. So that would be C, G5, T2, P1, A1, L4. That makes sense to everybody? Even with the twins and stuff?
Sorry, you said the twins is 1 pregnancy?
Or twins should count as 1 pregnancy. Yes.
Okay.
The
Yeah,
twins
that's what I
should
was
count
going to.
as 1 pregnancy and also as 1 delivery.
Just to confirm, the only time that you would count the twins separately is under the L for living.
Yes.
So if they were born preterm, that's why it's 1 preterm delivery.
Yes, correct. Yep. So we've had a total of 5 pregnancies because she's pregnant now. She has that 2-year-old son born at 40 weeks, which is her second. She has a 5-year-old daughter born at 38 weeks, which is her third. Her twins that were born at 35 weeks, which is her fourth pregnancy, and then her abortion, which would have been her fifth. Term would be 2 because of that son that was born at 40 weeks and the daughter born at 38 weeks. Preterm would be 1 because of the twin daughters that were born at 35 weeks. And then abortion is 1. And then her living would be 4 because that's the only time, like we kind of said, that we're going to count twins as separate, is when we're counting them as living children. But any other time, you're counting it as 1. Okay?
All right, I have a question.
Yeah.
Oh, you can go ahead. It's about this. When we looked at a different question before, it had a stillborn. What about babies that are born alive and then do they are they considered living, or it's just for, I don't know,
So you
because
mean
they were born.
infant was born and then passed away like later in life?
Yes, but then are they not considered like
So that would still be considered a living, we would still put that child under living, but very, that is a hard one to answer because so typically, like if I was getting a report from a nurse, they would have like, okay, they have four living children, but one of them passed away when they were 2 years old or something, but we would still consider that living because the baby was born alive. Okay. Stillborns are a little different just because they were never alive or were breathing on their own or anything at delivery. So that is the difference. But if your baby is born alive, then we would consider that in the L's. And then if something were to happen later in life, we would just mention that in the report, but it would still count as an L on the mnemonic. It's a good question. A client who thinks she's pregnant comes into the prenatal clinic to begin care. Which data provides the most definitive confirmation of the pregnancy?
D, as in dog.
Yep, you got it. Fetal heart tones auscultated by a Doppler. The other ones, so amenorrhea, not having a period, would be presumptive. Positive Chadwick sign would be probable. And then changes in breast pigmentation would be presumptive too. The nurse recognizes that an expected change in the hematologic, I can't say that word right now, system that occurs during the second trimester of pregnancy would be what?
An increase in blood volume.
Yep, you got it. An increase in blood volume. So, another thing, so a decrease in white blood cells, your white blood cell count is going to increase in pregnancy. That's a typical thing that we would see. An increase in hematocrit and a decrease in sedimentation rate isn't anything that we're really overall too worried about. But our blood volume is going to increase by quite a bit in pregnancy. So something that I talked about in this week's recorded lecture was the changes in the blood volume and also in the cardiovascular system of a pregnancy. Those are definitely things that you guys are going to want to review and know for your exam. What our cardiac output looks like during pregnancy, why those changes to our hypertension occur, what our plasma volume is doing, why we would be hemodiluted. So when you're listening to the recording, if you haven't yet, definitely pay attention to that part of it because that is really important and it's going to lay the foundation for when we start to talk about gestational hypertension and preeclampsia and eclampsia and all that stuff. So it's important to know that right now. Alrighty. On admission to the prenatal clinic, a 23-year-old woman tells the nurse that her LMP began on February 15th and that previously her periods were regular. Her pregnancy test is positive. The client's expected date of delivery would be what?
C. November 22nd.
November 20. It would be November 22nd A. So we'll count back. So February 15 minus 1 month would be January 15th. Minus 2 months would be December 15th. Minus 3 months would be November 15th. So November 15th, we would add the 7 days, and that would be November 22nd. Okay. So like for your guys' tests and stuff, you will be permitted to use a whiteboard. So what I would do is like once you start your test, like write down that formula so that you have it. So then it's just a matter of like calculating it in your head, but that you don't have to try and remember the formula. So jot that down at the beginning.
I do have a question. I know you said that we can't use Google for calculations during the quizzes and the exams. Can we use like a calculator, like a small calculator?
Like an in-person calculator?
Yeah.
Yeah, that should be fine. I just would have to see like the front and back of it.
Okay.
Yeah, I know that ExamSoft has a calculator built in, but if you guys want to use one, I think that should be fine. I'll clarify with Professor McBride because I already gave you wrong information about the quizzes, so let me just check on that. But I think that should be okay. I would just need to see the front and back of it. Okay.
I don't know if ExamSoft allows you to use the calculator on all the questions or if it just picks and chooses which ones it thinks you needs it on. You need it on. I'm not really sure though.
I see where
It's a tool that's in Exemplify the whole test.
Oh, the whole entire test. Okay.
okay.
Thank you.
Yeah, so you can use that if you're more comfortable with in-person one. I'll just have to make sure that's okay. You guys have it. I'll check in with Professor McBride on that just so I don't give you wrong information. Okay. But remind me next class because I'll text her tonight and then I probably will forget to say anything. So just keep reminding me. All right. A 34-week gestation multigravida comes to the clinic for her bi-monthly appointment. Which assessment findings should the nurse report to the healthcare provider?
The heart rate being 110 beats per minute.
What is our
1 plus edema.
It is actually her fundal height of 30 centimeters. So edema in the lower extremities with a pregnant lady is normal. They're going to have some swelling. The only time that we are really worried about swelling is if it's sudden and it's extreme. Okay, so like I'm talking like this patient had a normal looking foot and now all of a sudden it's a marshmallow. Okay, that is what we're worried about. She has like pitting edema in her lower extremities randomly because that could be a sign or symptom of preeclampsia, is sudden onset of edema. +1 edema on her lower extremities is okay. Fetal heart rate. So a fetal heart rate for you guys, for your reference, I would write this down. A normal fetal heart rate is 110 to 160 beats per minute. So that would be okay. Is it a little on the lower end of that? Yes, but it's still within those normal range. A weight gain of 2 pounds at this stage of pregnancy is okay. Usually in the third trimester, they're gaining about 1 pound to 2 pounds every week. Okay. Our fundal height is concerning because at 34 weeks gestation, let me see if I can find a chart or a good picture to pull up for you guys. So let's see. That is tiny. So here we have a picture here of the total amount of weeks and what the top of the where the top of the uterus or that fundal height should be at. Okay, so you can see at 12 weeks it's down here, 16, 20, 26, 32, 40, 36. So we're going to be measuring um, the fundal height at almost every appointment, especially when she gets into her third trimester. So the fundal height should match the number of weeks between the 20th and the 36th. So whenever, oops, I don't know what happened there. So whenever we look at this question and she's 34 weeks and her fundal height is only measuring at 30 centimeters, her fundal height is too small. So that could be indicating that the baby, we're experiencing fetal growth restriction, intrauterine growth restriction, or like why is her fundus not growing or why is her uterus not growing the way that we need it to? Okay. So that would be an easy way to think about it is that it should match the number of weeks of pregnancy from 20 weeks. Okay. All right. A pregnant woman at 32 weeks gestation complains of feeling dizzy and lightheaded while her fundal height is being measured. Her skin is pale and moist. The nurse's initial response would be to what?
D.
Yeah, we want to turn her on her left side. So when you measure somebody's fundal height, they're usually laying on their back. Okay. So that can cause that supine hypotension that we were talking about earlier because that baby is pressing down on mom's vagal nerve. It's restricting the amount of blood flow to not only baby but also restricting mom's blood flow, and that can cause her blood pressure to drop drastically. So yeah, turn her on her left side. That's gonna help increase blood flow not only to mom but back to baby and back to the placenta. The nurse has given the client this information on maternal serum alpha fetoprotein screening. Which statement by the mom indicates that she understands the screening results?
B.
Yep. AFP level is high. It could indicate a problem with the baby's spinal cord. So A, if the test is negative, it means that my baby doesn't have any birth defects. So just because they don't flag an AFP does not necessarily mean that a baby will or will not be born with Down syndrome or with neural tube. It can still happen, okay? If AFP is low, that just means we're going in the wrong direction. And then Down syndrome only occurs or can be at risk if the AFP is low, not high. Following an amniocentesis, a client verbalizes several complaints. What complaint indicates to the nurse that the client is experiencing a complication from the amniocentesis?
C.
It would be B, low back pain with pelvic cramping. So when we talk about amniocentesis, the thing that we're most worried about with them is miscarriage. So low back pain and pelvic cramping can indicate that the mom might be laboring or about to miscarry. So that would be a lot more concerning. A headache and blurred vision would be concerning, but in response to an amniocentesis, we're not really going to expect to see that. It would be something we would want to like investigate further, but we're not anticipating that. Directly related to an amniocentesis, we're more worried about that low back pain with pelvic cramping because that can indicate a miscarriage. All right, the nurse is providing anticipatory guidance for an African American client who is at 24 weeks gestation. What prenatal laboratory assessment prescribed at 28 weeks should the nurse include in client teaching?
C.
Our 1 hour glucose. Yep. All right, so we've got about like 6 minutes until I let you guys go. So we are going to, let me stop this share. We're just going to go ahead and review the things that we need to have done for this week. And then we'll talk a little bit about next week too. So next week you have quiz number 2. Okay, so for the quizzes, like I said, we're going to need to have 2 devices for the quizzes. You guys will, unfortunately, throughout the entire term, if you have to be like in a car or somewhere else during class, unfortunately, you're going to have to ask you to just like come into the Zoom whenever you're able to and whenever you're in the spot that you aren't in a car or wherever. So for the quiz next week, just if you have to miss it, let me know. But try and be in class early if you can. This quiz today, we kind of had a little bit of time extra just because it was the first one. You know, we have that like learning curve of getting everybody on track and ready to take the quiz. So next week, just be in class a little early. We'll start that quiz pretty much right at 5:30 p.m. Okay. We have the discussion post and you have your sim chart that is due by Sunday. Okay. If you guys want to set up meetings with me, feel free to. I don't have office hours posted, but we can always meet in person anytime if we figure out a schedule. Okay. Same thing is going to apply for next week in class. I'm going to post a recorded lecture that you guys should hopefully watch before because your quiz for next week is going to have content from this week as well as content for week 3 on it. So it'll be for your benefit to watch the lecture before you come to class to prepare for the quiz. And then we'll have another PowerPoint that you guys will be able to follow along with during class, okay? We might do an activity next week. It just depends if we have time or not. It'll be like a little teach the class type of activity. But as long as nobody has any questions, since we didn't take our break today, we can probably go ahead and leave early. So, does anyone have any other questions before I let you guys go? Nope. All right. As long as everyone's feeling good about the quiz and what you guys are expected to have finished for this week, you guys are happy. You're good to go. So, if anyone needs to stay after and talk about any assignments or any grades or anything like that, please feel free to stay. Okay. But if not, have a good week.
Have a good night, Professor.
Good night.
So our quiz too, it's going to be on what we went over tonight, correct?
Yes, there will be
Okay.
content from this week, and then there also will be content from next